is just a huge honor for me today to be podcast interviewing my buddy, Dr. Geoff Sharpe, who was born and raised in the north of England. He graduated from Newcastle University School of Dental Sciences with distinction in restorative dentistry. He subsequently worked in the NHS as a senior house officer at Aberdeen Royal Infirmary and Manchester Royal Infirmary, gaining experience in restorative dentistry and oral and maxillofacial surgery before proceeding to full-time general practice. He later returned to Newcastle University for specialist training in periodontics. He graduated with a clinical master's degree and achieved membership in restorative dentistry and periodontics at the Royal College of Surgeons at Edinburgh. He was invited to Dubai in 2010 and became the periodontist at a renowned specialty clinic prior to creating the Perio Clinic. Dr. Sharpe lives in Jumeirah with his family. In their free time, they enjoy early mornings at the beach, camping in the desert, and exploring travel opportunities to Dubai. Thank you so much for coming on the show today.
Well, thanks for having me, Howard. It's so great to meet you, and thanks for your time. I've learned so much from your other guests in the past, so I hope I can share something that might be of interest to you and your listeners.
Well, the first thing I want to talk about, of the 10 specialties, periodontics was turned upside down the most. But before I go there, you're a very rare bird. Only 1% of humans out of 8 billion are living today in a country they weren't born in. And you were, from England, and you went to another country. Usually you go to another country for love or a job. And you took, did you meet your wife in England, or did you meet her in Dubai, or?
We met here. Yeah, I came here as a single guy.
Tell us the story. How did you go from England? What is that, 10,000 miles away from Dubai to England?
Maybe not quite as far as that, but yeah, it's what happened was, you read my bio. Thank you. You make me sound probably better than I really am. But I became a specialist in the UK. I spent my whole life in the north of England prior to coming here, and the private dental market in that region was relatively small. And what I found was, in order to keep busy doing the job that I love, I was working part-time in a number of different clinics. I was all over the place. I was doing a day here, a day for somebody else, traveling a lot around the country, spending hours on the train. There were some weeks when I'd be in hotels, and I loved the work. I loved what I was doing. I finally got to be a periodontist, but I found I was making life difficult, and the whole thing was quite inefficient. So I did it for a couple of years. I learned what I could. I had some fantastic mentors. But yeah, at that time I was still single, and I started thinking outside the box and thought, what else can I try? How can I make this better? And there just happened to be a vacancy here in Dubai. There was an American periodontist who was about to retire from his role, and the clinic needed a replacement. And I thought maybe this could help me out for a couple of years while I save up and get on the track to having my own business. So I came out to Dubai. I met my colleagues, and what I liked about, Dubai is an amazing place. It's totally unique. We can talk about that in a bit more detail if you want. But at that time, to be honest, the thing that really sealed the deal for me was the fact that I was going to take over from an existing periodontist. He'd been there for a long time. He had a patient base. He had a referral base. And for the first time, I could come to work in the same room, see my patients, have control of the environment, and have my desk in the corner and just focus on doing a good job. And the fact that it's in a nice warm country with lots of interesting people and all of that sort of stuff, it just sort of added to it, really.
So I did another podcast with a gentleman who practiced in Dubai, Michael Appa, who has an office in New York and Dubai. Is he one of your homies that you hang out with in Dubai?
Actually, I've never met him. I think he flies in, he does his treatment, he goes home again. I hear he just opened an office in LA as well, so he is all over the place. Of course, he's very well known. He's got millions of followers on Instagram, but he doesn't. I don't think he spends a lot of time here with other dentists. I know his hygienist extremely well. I know Beverly. She's been here a long time. But I never met Dr. Apper. So yeah, he's obviously built his business here, and I think off of the back of his very famous clinic in New York. But I tell you, he's extremely successful. But I don't know if I'd want to do what he does. I mean, I was exhausted just traveling around the UK, and he's flying around the world doing his veneers.
Oh, I know. It's a different lifestyle. I've had to do all those long distance flights all the time, and what I decided right out of the gate that I wasn't going to listen to music and I wasn't going to watch movies, and I was going to. Whenever I saw like a nice 800-page textbook, you're like, well, that's a perfect 15-hour flight. And so I think about it. I buy the textbook. Because when you're at home, it's just so hard to get in the zone for those many hours. But that's neat. You went where the money was. I mean, you saw more economic opportunity in another country. I've dealt with this for 3 decades in America. Some kid born in a town of 5,000. The factory closed. Now the town's 2,500, and he's asking me how to grow his business. And I'm like, you do know you can move, right? And people just, it's romantic. They want to go down with their ship. You know what I mean? And I just think it's so cool that a guy like you can think outside the box. So then you met your wife there too. Was she in dentistry?
Yeah.
Or?
No, she's a school teacher. So I've been here a couple of years, and we met cycling. There's a kind of an ongoing joke among the expat community. We all came out here for 2 years, 3 years. I had this rough sketch that I was just going to save hard and move back to the UK. And, the time just goes so fast. And I mean, I'm going to be here 10 years next year. And Kim and I met here. As I said, she's a teacher. She's Canadian, so from different countries. And so we had a conversation, we sat down, and Dubai, we both love it here. It's kind of neutral territory. I think there might be challenges for me to jump through all the hoops to actually practice in Canada. We sat down and we said, why don't we make a go of it? Let's open a clinic here. I really have to thank her for supporting us while we did all of that. I literally couldn't have done it without her. My whole days were spent just, up to my eyes in admin and contractors and building and ordering stuff. And Kim just, she was my rock throughout all of that. And then, as you know, we had a baby last year. So I'm so glad that we set up the clinic when we did, because I don't know if I'd have the energy these days.
So the big cities there are Dubai and Abu Dhabi. Are they pronounced the same like that? Is it Dubai and Abu Dhabi? Or
Abu Dhabi is the capital.
Abu Dhabi and Dubai?
Yeah.
And which one are you more close to?
Dubai, very much so. Yeah. So Dubai tends to be a little bit more high profile, but Abu Dhabi is the capital city. So the country is known as the United Arab Emirates, and there are actually 7 emirates here. In I guess a similar way to states in the US. You've got 50 of them. We've got 7 emirates, and Abu Dhabi is the capital. And it's the biggest geographically. Dubai has more people. There's 3.2 million people living in Dubai, and there's, I think, 9.5 million living in the whole country. And then there are 5 other smaller emirates. There's Sharjah, Ajman, Al Quwain, Ras Al Khaimah, and Fujairah. So those are probably somewhat less well known around the world. but together they make up the UAE, the United Arab Emirates. So that's the country where I am now.
So when you're in a foreign country, you're from England. You're in Dubai with 3 million people. How are you accepted by the patients and the competition, the other dentists? Does a dentist across the street, is he glad a dentist all the way from England came to compete with him across the street? Or does he like that? Does he not like it? How does that work?
Yeah, okay. So the first thing to understand is that the population of this whole country is heavily skewed towards people like me. The local citizens, the Emiratis as they're known, the people that are born and raised here and have a UAE passport, there's 254,000 of them in Dubai itself, out of a total of 3.2 million. So they make up less than 10% of the total population of the city. So we're an extremely mixed group of nationalities, cultures. Everyone that came here has got their own. I mean, you just heard my story. Everyone else, all my patients, they've got similar stories of their own about why they were drawn to this place and how long they've been here and their family background and so on. So it's a really, really unique place from that point of view, and that is one of the things I think that's kept me here, because my patients are fantastic. They're so grateful. They're interested in what we've got to say. I know. I mean, as well as anyone, that people typically don't like visiting the dentist. It's not usually their favorite thing to do. But I find that here, more than anywhere else, people do tend to appreciate what we're doing, and they say thank you, and they thank the nurse. They thank my assistant. So it's so much fun meeting people, and it's so much fun having them as my patients here. And for the other dentists, I think a lot of them are in the same situation as me. They're not necessarily, in fact, probably quite a small number of them are citizens of the UAE. They're all foreigners like me that have got a license, and they either work in a clinic or they have their own clinic. So yeah, there's a community. I'm blessed to have some really, really great colleagues that refer to me. Some of them I met when I first arrived. Some of those relationships have developed over the years. But I think, as with so many other places, the landscape is changing, and we're seeing bigger and bigger group practices, things staying in-house. I don't necessarily think that's always best for the patients, but there's a community here, and as I say, we're such a wonderful mix of nationalities and backgrounds, so it's fun.
Well, you said something very subtly just now that just punched me right in the face. I mean, it's of importance. You said you've been the visiting specialist, and you believe this serves the business owner probably more than the patient or even the specialist. So I think dentistry should be patient-centered instead of dentist-centered. What did you mean by that?
Well, going back to my days in the UK, I told you I was that visiting specialist in quite a few clinics. And right from the beginning, I was asked by quite a few practice owners to come and join them. They found out I graduated. It's like, hey, Geoff, we'd love to have a periodontist for a day a week. And it's flattering, when you're in that position and you're being headhunted. It makes you feel valued. But to be honest, I never felt comfortable being the part-timer in somebody else's business. And I get it from the business owner's point of view. They want to offer that one-stop shop. They don't want to refer patients outside. They feel like they're sending business out the door, which I don't think is the right way to see it, to be honest. It shouldn't necessarily be like that. I think we should want our patients to have the best care from the right person, whoever that is and wherever they are. So the telltale sign for me is that associates are never the ones saying, "Hey, Geoff, I'd love it if you could come and work in our practice. Let me ask my boss if we can have you for a day a week." An associate calls me up and says, "Hey, Geoff, I hear you're this periodontist. Where do you work? How can I refer to you?" So they just want the patients to get the right care. They have no skin in the business of it. They just want the patients to have the right treatment. And to be honest, I don't know if patients really mind going to another clinic. This is the other argument. Practice owners always say, "Oh, my patients know us here. They don't want to go somewhere else. They know where we are." But I think if they've got to get in their car and drive 10 minutes to practice A, I don't think it really matters if they get in their car and drive 10 minutes to practice B. They just want to get the right treatment. They want to know that they're being sent to a trusted colleague who's going to do a good job. And I think if it's done right, referring outside can actually help the relationship between dentists. The first thing I say to a patient when they come and see me, I say, it's great to meet you. Dr. Farran told me all about you. I'm so happy that you're here. I know he would have loved to have treated you himself, but he obviously just wants you to get the right treatment. And he's a great dentist. And as soon as we finish with you here, then of course you're going to go back to him and he'll carry on with all of your routine checks and everything else that you need. So I try and big the referring dentists up as much as I can. And I think too, people don't always appreciate that these referrals can go both ways. If more and more people land on my website, they find me, they think they need to see me, they come in for the consultation, but they might need treatment that's outside my area of expertise. So what am I going to do? Well, of course, I'm going to refer that patient to somebody that I trust. And that's probably going to be a patient that refers to me. So it doesn't have to be patients that are referred are never seen again. I think it should be the opposite.
So, my gosh, do they love Tom Cruise in Dubai after he jumped out of an airplane 8,000 meters in the air and had, is he a big deal in Abu Dhabi?
I think so, yeah. I mean, we're exposed to the same movies and TV shows that you have in the US and elsewhere. So, I think it's always nice when somebody or something like that puts Dubai on the map. We're all quite enthusiastic about the city. Next year, 2020, Dubai won the bid to host the World Expo. So the government and everybody here is really, really focusing on that now. I think that's going to be huge. And every single country from around the world pretty much is going to have a pavilion here and get to showcase their country. And of course, they're all going to come to the UAE and we get to showcase what we have to offer.
So talk about the expo, the World Expo. Is that a really big deal?
Yeah, it's huge. It was announced a few years ago that Dubai had won the bid to host it, and ever since then, it seems like almost every sector has been really full steam ahead, getting everything ready. There's a huge new airport being built. There's the expo site itself. There's I don't know how many thousands more hotel rooms. It's just been a big push towards this expo that takes place towards the end of next year.
And that actually started in London in 1851. So that was a British innovation. The first World Expo. So my first question, whenever I'm talking to a dentist in another country than where I was born, the first thing I always want to get to is epidemiology. I mean, there's people listening to you from a lot of countries right now. how is caries, perio, and occlusal disease? Is there any differences between caries, perio, and occlusal disease in, say, Dubai, United States, Canada, England, Vietnam? I mean, do they have unique factors in diet, home care, culture? Does anything, do they have water fluoridation? How is it different? You obviously know England and Dubai. So how are they different from an epidemiological point of view?
So yeah, to share some of my own experiences on that. I mean, I don't have access to any hard facts and figures to back it up. Water fluoridation, no. We typically drink bottled water here. The drinking the mains water supply is safe. We're always being told that it is safe to drink, but I think the issue comes not from the supply, but from the storage in the individual buildings. I guess it just depends on the individual home or apartment building, how clean or otherwise that water is stored. So just everybody drinks bottled water, so that's not fluoridated. In my experience, yes, all three of those diseases that you mentioned, caries, perio, occlusal diseases, they do seem to be much more prevalent here. Now, it's hard to know exactly why. And again, my patient base, they literally come from, you could pick a country, and I've probably got a patient who comes from that country. They're not all born and raised right here in Dubai. In fact, probably very few of them are. Most of my patients are expats just like me. So they will have been exposed to whatever influenced their upbringing in Europe or the US or Australia or somewhere else in Asia. So there's an awful lot of variables. What I can tell you is that here we have an extremely high incidence of diabetes. So that has a huge impact on my work as a periodontist. The latest figures say that 19% of the population of the UAE suffer from diabetes. What we don't know, of course, is how many people are undiagnosed. There must be, millions of people walking around with undiagnosed type 2 diabetes. So that's extremely high. That has an impact on perio. Similar thing, I think, with smoking. Smoking is kind of, it's almost part of the culture here. A lot of the Arabs smoke shisha, the water pipe. So that's extremely popular. Tobacco is cheap anyways. They recently slapped on a huge excise duty on cigarettes, but still, I think they're much, much cheaper than other countries around the world. So high incidence of diabetes, high incidence of smoking. I think both of those raise the incidence of periodontitis. I don't personally treat a lot of caries, but I see a lot of it. So I think, to answer your question, dental disease is pretty high here.
Yeah, they that region has the highest, one of the highest in the world. I mean, of diabetes. And the two main causes of diabetes are genetics and lifestyle. But you know what? Every humans always you see the same errors as you jump from different genres. But like in stocks, like from 93 to 2000, people just kept linearly extending that line. And they're writing books, Dow 40,000. And I think as the diabetes starts rapidly going high, those young baby kids are going to be looking at dad sitting there on that couch fighting diabetes with a cigarette in his hand, eating Burger King, and say, not for me. So I have so much faith in the individual, and I think what goes up must come down. It's all cycles, but they'll figure it out. But it's a first world problem because it's from being real rich real fast, right?
Yeah,
I agree. And it's funny because I remember one time I was in I forgot where I was. I think it was I think it was Tunisia. Where's but anyway, yeah, it was in Tunisia. And you'd see the rich people, and this dentist was laughing. He says, "See that guy in that Mercedes Benz? You know, he thinks he's on top of the world. But look at him getting out of the car, and he was obese and all this stuff. And then you think the people walking down the dirt road were poor and they were sad, but all they had six packs, they're giggling, they're happy, they're healthy. And it's like, someone might think from far away the guy in the Mercedes rich would be happier, but you'd much rather be that poor kid walking the dirt road giggling with his friends than driving in that rich Mercedes. I actually, I can't say I feel sorry for periodontists, because when you compare how much feel sorry for pediatric dentists, no one else even makes the list. I'm just, I can't believe those guys even exist. But anyway, Perio, when I got out of school in 87, it was all this training and everything to save the tooth. It was scaling and root planing and every 3 months. And they would just go to the moon to try to save that tooth. And it wasn't even 10 years. People thought, you know what? You know how you treat perio? With titanium. Let's pull that stupid tooth out. It's useless. We can improve the human condition by pulling out natural parts and replace them with titanium. And that went on for about 10 years. And now everybody I see looking at that and saying, well, that wasn't so much a good idea. And now you see the pendulum swinging back to wanting to saving some molar with a trifurcation and a 9 millimeter pocket. And my periodontist's like, let's just try a little more. So that pendulum went from all perio to all titanium, and it's come back. Where should that pendulum be if it was hanging still on the bottom instead of swinging right to left? Where should the pendulum be? You're talking to a lot of kids right now, and it's tough for them because they come back, they come out of school, they go back and work with their mom and dad, and they're sitting there looking at this tooth, and it's had an 8 millimeter pocket every 3 months so where should the pendulum rest?
Yeah, that's a great. You've nailed it, Howard. That is the issue, I think, of the day, and it's a great question because it has, as you say, it's swung from not just wanting to save teeth at all costs, but not really having access to implants. Remember back in the day, they were supremely expensive, and they were only available to a limited number of people. I qualified in '98. And I think, a good bit before that, you had to go on Bronnemark's own course before they would even sell you the implants. So they just weren't accessible to a lot of dentists and therefore a lot of patients. And of course, since then, the implant market's boomed. You've got thousands of different companies making implants, and the training has become more and more accessible. So I think a lot of that contributed towards this shift towards giving up on teeth, in my opinion, a little bit too soon, and swapping them out for titanium. And I think it's right that the pendulum is swinging back. I think there's an awful lot that we can do now to save teeth, or at least really slow down that rate of bone loss. I don't really buy into this concept of having to extract teeth to preserve bone. I think there's a lot of work we can do to preserve good functional teeth without resorting to extracting them all. And then who knows what's going to happen in the future? We've got, periimplantitis going through the roof. So I think it's only right that pendulum swings back again. And where we can predictably keep teeth, then we should do so. And if we hang on to a tooth for another 5, 10, 15 years, well, that's another 5, 10, or 15 years that you could add on to the life of your life expectancy of your implant. So I think the pendulum's coming back, and I think implants definitely have their role, of course. But I don't think we should be too hasty to just do this wholesale extraction of teeth that could potentially be maintained.
How long have you been a periodontist?
I finished my perio training in 2007. So
12 years?
12 years.
Okay,
Yeah.
so over a decade, 12, 13 years. How, as a periodontist, you always wonder, like, who are you, the periodontist, and you wag your tail, or does the referring dentist wag you around? I mean, how many implant systems do you have to keep your referring doctors, or do you think that's a wrong approach to a relationship? And when they say, "Hey, I want you to place Noble Biocare or Strawman or Dentsply Sirona or Zimmer or BioHorizons or Implant Direct or Hyasun or MIS," you say, "No. This is what I use. The patient comes first. I use one." How many implant systems do you have?
To be honest, I have one.
You're the first one I've met that has one. What is your one?
It's Astra. I've been an Astra user for nearly 10 years. And again, I'm kind of I know I'm in this sort of slightly unusual position, but because I came here and didn't know anybody, and the practice I was working at the time wasn't offering implants, I set up that implant service from the beginning. I was in a fantastic position to be able to look at all these different systems and choose what I felt was the best one at the time. And then when people started referring to me, it was kind of like, "Can you help me with these implants?" And this is the system that I'm using. So, I still only use one. Of course, I'm always thinking about adding other ones, but there is a lot to be said for getting familiar with one system, know it inside out and back to front, know exactly how it works, and having some consistency. I think sometimes we're in danger of saying, "Oh, he or she is a specialist, they do things better." I don't necessarily think we do anything better. I think we just do a limited number of procedures. We do them the same way every time. We know what works, and we thrive on consistency in all areas if possible. So I like to have one implant system. I have used others in the past, and I'm not saying I wouldn't use any others, but I think there's a lot to be said for just picking with something and sticking with it.
Another thing that's all over social media is that periodontal disease causes heart disease. And then you start getting the big debate. Okay, when I got up this morning, this is a true story. I turned on my coffee pot, and every time I do that, the sun comes up. And I know it's me. How else could the sun come? So how do you, is this a teaching lesson you share with patients? Is it something you keep to yourself? Do you believe it, not believe it? What would you say if a patient said, "Will my gum disease cause a heart attack?"
I think what I say to patients like that is that we are seeing more and more associations of gum disease and heart disease, and those two conditions seem to occur together in similar groups of patients. I still haven't seen any really compelling evidence to say that if we treat your periodontitis, you're going to reduce your risk of having a heart attack or heart failure or whatever. So I think a lot of these suggestions are pretty plausible. I mean, you had Dr. Bradley Bale on your show. He gave a fantastic interview with you, and I read his book, and now I eat 99% cocoa chocolate every day. But I think we're just at risk of overplaying our hand a little bit here. If dentists or periodontists are always the ones saying, "Hey, we've got to treat this gum disease because you might get a heart attack," it kind of makes us look a little bit desperate if we don't have some really compelling evidence to show that what we're doing is going to offset that. I think much better would be if ever there was some really good evidence to persuade everybody that this really was a genuine causal link between inflammation in the mouth or specific pathogens in the mouth and cardiovascular disease, then the ideal scenario would be to get cardiologists on board. and have them driving this. Have cardiologists be the one to say, wow, we found this in your bloodstream, or we found this bacteria. You really should go and see your dentist. I think if they are the ones advocating for us, that is so much more powerful than dentists scratching around, desperately searching for a way to treat more people.
So you've been using Dentsply Sirona Astra for a decade doing these implants.
Yeah.
And so my question is, when they talk about implant failures, it's so tough to talk about, because when you look at the studies, they're always putting them in, D4 anterior bone to wear health. It didn't even work. It'd still be wedged and stuck in there, as opposed to a maxillary bone. Did it fail out of the gate because, it just never took, or did it fail long term? But when you look at the implant, let's start with periimplantitis. Do you think the major implant companies that some surfaces are less likely to get periimplantitis than others? Or do you think periimplantitis, like we were talking about diabetes, is more to do with genetics and diabetes and smoking, as opposed to the surface of the implant? Because remember, they used to have HA-coated implants, hydroxyapatite-coated implants. So
yeah. If you look back through the history of implants, the very first cases that were treated, they were all edentulous patients. They were done in Scandinavia. People who'd been wearing complete dentures for years, and they had these. Of course, they had resorbed bridges, and they had these like oil rig style prostheses, huge long abutments with a fixed lower bridge. And two things. First thing is, those are really easy to clean. They're far away from the tissue, and they had meticulous follow-up. They were always seeing hygienists. They were always being instructed how to keep all of that super clean. And I think when implants are placed in an edentulous mouth, then there is no PG or AA or any of these horrible, nasty pathogenic bacteria, because all the teeth are long gone. So I think dentists at that time saw how successful implants could be, and they realized that osseointegration was predictable. And I don't think they saw anything like the amount of periimplantitis that we're seeing now. Then I think as a profession, we got carried away and we start pushing the envelope. And as you say, newer surfaces were developed, rougher surfaces to allow the implant to integrate much faster. But as soon as that surface becomes exposed to harmful bacteria, particularly in a partially dentate mouth that still does have all these perio pockets, then of course that surface is going to get colonized quite quickly, and then we see this huge amount of bone loss that progresses very fast around an implant.
So another thing that dentists do, I always call it a red flag when I see it in our tribe and not a bunch of other tribes. But man, you could talk to 100 physicians for 10 hours each, and none of them would mention any brand name equipment they have. You talk to a dentist for 5 minutes, and he's telling you he's got a laser, he's got a nap, he's got a CAD cam. It's almost like their whole ego is defined by their technology. It's kind of like in Kansas, those boys when they were 14, they wanted the big old pickup truck. That it was the modern day cowboy riding a horse. But this stuff's expensive. Like Lanap's $135,000, and I got kids listening to me that have student loan debts. They bought a practice. They got kids. They got to tuck in at night and feed, and they're asking, I want to treat periimplantitis. I'm trying to be an implantologist, or I'm a periodontist. Should they buy a $135,000 Lanap to be as good, better periodontist like you?
They could. I don't have experience of Lanap. I didn't invest that money in a laser. I feel like there are still conventional treatment modalities that can be effective. Now, interestingly, the AAP, the American Academy of Periodontology, they came out with a paper in 2018, and it was one of their sort of best evidence consensus guidelines about the use of lasers in the treatment of periodontitis and the treatment of peri-implantitis. And they were still fairly equivocal on the use of lasers for treating both of those conditions. A lot of their members are LANAP certified, and I think if you're spending that kind of money, then of course you're going to find reasons to use it. But the AAP are still on the fence. You know, they know that there are other things that can work, but I detected a sense that they're keeping the door open for that landmark study that might appear that says that actually, yes, lasers are far superior and therefore that's going to be the standard of care. But I don't think we're there yet. I think that's it's really the choice of the individual dentist. If they're really, really into that kind of technology, if they think that there's a market for it, if they think they can use it, if they can, do enough treatment with it to afford the repayments, then why not? It's another string to the bow. I think there are many different ways of dealing with all of these different conditions. And again, it all comes back to consistency, finding the way that works best in your hands, learning that system and deploying it.
Yeah, and I gotta teach the kids something. You know, I'm trying to teach them this a lot with channel conflict. So, you know, you have to, money's the answer, what's the question? You got to try to, when you're listening to someone else, you always got to say, what is the cultural power, you know, what could be a reason to explain this? Well, what is the American Association of Periodontists? What is their ultimate goal? To get every single periodontist on earth to be a member. So what would be really dumb for them to do? Oh, let's say piss off every one of them that owns a laser and loves LANAP. So, and the ADA, when I went down there to 211 Chicago, I went down there one time with Gordon Christian and we were talking to those guys and one of the reasons they don't like to make a lot of decisions, they don't want to fracture the herd. You know what I mean? So it's like when they start talking about a television commercial for gum disease, your profession, 5 years they couldn't agree on the wording of a 60-second commercial. But the president of the ADA is like, but it's good because it's like therapy. They're talking, they're working on it, they're working out their angst. And now, are they ever going to make a damn decision? Of course not. They could never make a decision. They said you can't get 100,000 dentists to agree that today is Monday, let alone what you're going to say on a commercial. So I wouldn't look for the American Association of Periodontists. If you wanted to find another reference for lasers, who would you go to? Who would be your next best idea? Someone that would have as much prestige, but less channel conflict.
Well, I think it's hard to find someone that's truly independent. If you've invested all that money in a laser, then you're damn well going to use it. It's not going to sit around in the cupboard gathering dust. So it's really polarized the profession. I think there are those that have invested that money, and by the way, we're seeing a rise in treatments like LANAP, which is trademarked. You can't just buy any other laser and say you're offering LANAP, because unless you buy it from Millennium, it's not LANAP. It might be a similar laser with a similar wavelength, but they've protected their intellectual property and made it a treatment of its own. And this is an interesting development because, back in the day, dentists would come up with something new. They would publish their findings in a peer-reviewed journal. They would open it up for scrutiny. They would publish their method, their results. That allows other scientists to try and duplicate their work and see if it was a one-off fluke or see if it really does work. But now a lot of these things are shrouded with copyright and patents and trademarks. So on the one hand, I kind of admire the people that have done that to protect their hard work, but it allows for a lot less transparency these days. So it's hard, to answer your question, it's very, very hard to get a truly unbiased opinion on what really works and what doesn't. Do you agree with that, Howard, or not?
Absolutely. My problem is when I pull up that paper, the website's coming up in French, and I'm like, okay, I don't know what I did. So on peri-implantitis, so we talked about lasers. What do you think is the biggest risk factor for peri-implantitis? Well, first of all, how significant do you think it is? So let's say you placed 100 implants, and at just 10 years, one placement, 10 years, what percent have peri-implantitis? And of those, how many are going to have to be extracted and redone?
Yeah, that's a great question. I don't know off the top of my head what the incidence is. It probably is going to vary, but it's, anecdotally, we're seeing more and more of it. And, you talked about removing implants. That's obviously the last resort, but it's very, very challenging to manage peri-implantitis in a way that keeps everyone happy, because you've already lost bone. You're probably going to end up losing a lot of soft tissue around the implant. You're probably going to end up with a lot of exposed threads. And if that's in the cosmetic zone, then that's an absolute disaster. So it's just a horrible thing to have to deal with. When a patient comes in with peri-implantitis, they often don't have any symptoms. As far as they're concerned, that implant is rock solid. They can eat with it. It's not painful. But then you find these huge pockets and pus coming out and bleeding, huge amounts of bone loss on the x-ray. So I think the key thing really is to try and prevent it as far as we can. And in my opinion, one of the things that's vastly overlooked these days is at least offering some initial perio treatment while the teeth are still there. Get the patient on board, teach them how to look after what they have, and again try and shift that really harmful pathogenic bacteria to a slightly more favorable, friendly bunch of bugs. And I think even just simple non-surgical treatment can do that in a lot of cases. But I don't think just taking infected teeth out and immediately putting in implants, I don't think those bacteria disappear overnight. I think it takes time for them to evolve and for them to improve. So I'm a big fan of slowing things down a little bit to start with. At least try and stabilize some of that inflammation in the mouth, get the tissues a little bit more healthy. And then if the teeth definitely can't be saved, then of course implants might be an option. But I think then you're on a little bit more of a secure footing rather than just completely disregarding the etiology, taking the teeth out and putting implants in and then never seeing the patient again.
Another, this is Dentistry Uncensored, right? I like to talk about, the trigger points, the things that make people upset. In fact, if you're thinking about not sending me a hate email, please send it. That's, I want to know where your buttons are. I want to know how you're thinking and what you're thinking about. But all-in-4 is a very emotional deal. A lot of people, you start talking about all-in-4 and they mean, all-in-4, you mean none on 3? And, and they also, when you're a trained periodontist, your whole life you're trying to save bone. And then you go do an all-on-4 and they just whack off, a centimeter of alveolar bone, trying to make room for the prosthesis. And so I'm just trying to trigger a few buttons on you. What's your thoughts on all-in-4? Is it all-on-3? Is it not very conservative to have to erase a lot of alveolar bone to make room for your prosthesis? Is it common in UAE?
There are clinics here that do exactly that. Their whole treatment ethos is let's pull out every single tooth, and put in a bunch of implants. And it's all done in the same day. And I don't necessarily think that's the best option. There are situations where I think teeth could have perhaps been saved. And you've got to remember as well, Howard, I know you're into your facts and figures. The median age group in Dubai is the 30 to 34-year-old age bracket. I think that's young to be pulling out every single tooth. 85% of the population here are less than 44 years old. That's my age. So, we're dealing with a very, very young population. I think there's an awful lot to be said for maintaining what we can for as long as possible. And unfortunately, it does get a bit challenging because the population here is pretty transient. I talked earlier on about my own backstory. I thought I would be here for a couple of years, and here I am 10 years later. But there are people. There are so many expats that they might be here for 2 years, 3 years, or less, and then they move on to the next posting with their company or with their employer, and then a whole bunch of new people come in. So I think having the long-term follow-up and seeing people and establishing that relationship is much harder in this part of the world than it might be in where did you talk about Kansas, where people have been born and raised there for generations to come. We're dealing with a very, very mixed, transient group of people that come and go quite regularly.
So is your practice more likely to be expats, or is it or the originals? What do you call the people born in UAE?
They're Emiratis from the Emirates.
Okay, so Emiratis. So what percent of the 10 million is Emiratis, and what percent are expats?
I can tell you in Dubai as a whole, 9.5 million is the population of the country. 3.2 million is the population of the Emirate of Dubai. Only 254,000 of those are Emirati, so it's 10% or less. And I think those numbers probably transfer pretty well to my practice. We welcome everybody, but just because of the makeup of the country, the vast majority of the people that I see are expats, and we probably see maybe slightly more Brits or Europeans than anybody else, just simply because I'm a Brit, and people tend to feel comfortable with people from their own background. But as I said before, we've seen people from literally just about every country you can imagine. The local Emiratis are very, very hospitable, welcoming people. They're an absolute pleasure to treat. I think one of the reasons why I don't see quite as many of them here is they have access to healthcare through the Ministry of Health and the Dubai Department of Health. So expats are left to more or less fend for themselves in the private market, which is where we are. So there's just over 2,000 dentists in Dubai, 2,163. And nearly all of them work in the private sector. 1,947 of them are the same as me. They're in the private sector, serving predominantly the expat market. So,
we say in dentistry we got three diseases. They say cario, perio, and occlusal. And the occlusal is the most controversial. I mean, caries are caries, perio's in the middle. How much do you think perio is affected by occlusion?
Again, you like the controversial questions, Howard, don't you?
I'm trying to make at least 100 dentists on Dental Town just want to kill you. It's so emotional, but anyway, and I'm really excited about occlusal the most because it's been the most controversial for 32 years, obviously, but I think a lot of it's because in caries there's a lot of objective measurements. I mean, you look at bite wings in a dental school, everybody agrees that's a cavity, that's not, or a watch. Perio, you got the perio probing measurements. You see them every 3 months. You got all kinds of objective data. But occlusal, you don't. But now you do because, Align Technology owns Invisalign and iTero, and they've done millions and millions of scans. And then they got a lot of money, so they hired a lot of AI people, and everyone's saying, man, we're going to get measurements, objective data. They've been talking about this for 2 years, but I hear a lot of teams wrapping up with it. Glidewell's on it. A lot of people are on it. So occlusal, when you start looking at occlusal data from millions of scans, and you got a TMJ theory that can't account for this massive big data set with AI, it's going to change real rapidly. But right now, where do you see occlusal disease with perio?
That's a huge amount of data, isn't it? If you're talking about all of those millions of scans that Invisalign is sitting on, obviously Invisalign's typically done on, hopefully it's done on people with a healthy periodontium, and I think typically on younger people. I see occlusion as being a contributing factor to periodontitis, but I don't buy into the argument that it's a cause of it. I think once you've got a significant amount of bone loss, then the tooth is going to obviously be more likely to start moving. And then if you've got premature contact or some other type of occlusal interference, then it can progress quite rapidly. But I think you do need that bacterial assault and the immune response in the first place to actually start the inflammation.
Gordon Christian's research letter from 2018 said, anyone have pocket depth reduction in their practice using ProDentist, BioGaia, Cultured Care, Probiotic Gum, ProBio Pro, Revitin. Are you having any luck with any of that? Probiotics or gut microbiome or?
Mm-hmm. I think I'm not a microbiologist, but my feeling on that is that the microbiome, the oral microbiome, it's pretty well established. You got to work hard to influence that, and we know that a lot of these bacteria are carried throughout families, through generations, through genetic means, so they're passed down. And I think, you can take a probiotic and populate your mouth with friendly bugs, but I don't know if they're going to stick around for very long when you stop taking that probiotic. So I think again, it's always about you got to get the basics right. You got to get the patient in a situation where they are able to reliably remove those harmful bacteria on a daily basis, clean properly, especially between the teeth in all those difficult areas, stop the most harmful bacteria from ever developing, and maintain that healthy gram-positive aerobic mix rather than the gram-negative anaerobes that are going to cause gum disease and peri-implantitis. So I think it really does come back to those basic principles. And I feel like a lot of the messages that we should be giving our patients, they get lost sometimes in the noise of new trends or new research. The ADA, back home in the UK, the Oral Health Foundation, they're all very clear. You brush twice a day. You use a fluoride toothpaste. You clean between your teeth once every day. You spit out your toothpaste. You don't rinse it all away with water. You limit the frequency that you have sugar in your food and drinks. Those are the core messages that are not difficult for us as dentists to understand, but I think they get lost on a lot of patients because we've overcomplicated it, or we're too busy to explain it properly. And they come in with a cavity and they say, yeah, but I brush my teeth 3 times a day. Well, it's not about brushing. It's about your sugar intake. Do you know what I mean, Howard? I think
absolutely
those messages, they get lost sometimes.
So when you're when you're a periodontist for a decade and you see referring doctors and not understanding what you understand, what are their errors? What do they not get? I mean, obviously a periodontist, your personal framework is all perio, whereas a general dentist is spread out over. When we don't understand the way the elite periodontists think, where's our mental errors?
When you're, I don't want to start throwing people under the bus here, Howard. I rely on these dentists for my living.
No, not trying to get you thrown on a bus, but I mean, obviously, they know an oral surgeon can pull 4 wisdom teeth faster than them, and everybody knows that if you're a periodontist full time, you obviously know more perio than a general dentist. But...
Well, let me give you an example. If you compare it with, say, endo, you do a root canal for somebody, and unfortunately, for whatever reason or another, it doesn't work. They come back, they're still having pain. Maybe they've still, they've got an apical area, or the root canal's a bit short, or there's some issue with it. So no dentist normally thinks twice about sending to an endodontist and say, hey, I'm sorry, I've done my best. Let me send you to this specialist. Let's see what they can do. Now, an endodontist is probably going to do exactly the same thing again. They're probably going to use better magnification. They might use different instruments, but they're going to clean and shave that root canal. They're going to remove the old root filling. They're going to disinfect, and they're going to fill. But again, they've done it in that consistent way that they know works. They've got their routines in place. They've probably set up their practice to allow for all of those systems. They're consistent in the way that they do things. Sometimes I feel like dentists, hygienists, they do some non-surgical perio, and they refer to me, and they're expecting me to work miracles. They think I'm going to pull some, fancy surgical procedure out of the box that they've never heard of. And I examine that patient, and their oral hygiene's not good. I might find residual calculus here and there. And I really want to do some good quality non-surgical treatment to do it in the most efficient way that I can. Let's again focus on the basics, do things right. But I think that annoys people. I think there's something about perio that they feel like, well, I've done that. What do you mean you're going to do it again? I've already done that part. I want you to do something different. But it really is important to, particularly with perio, where the success or failure of the treatment really hinges on the patient's engagement. You can't just get your ultrasonic scaler and wave it around there for a few minutes and think that you're going to cure somebody. It takes time, and I think it takes time to explain the disease process, try and motivate the patient, absolutely focus on the oral hygiene, disclose. That's a massively underused technique. And it's completely impartial. If you use a disclosing agent, it's not you or the hygienist telling the patient that they're not brushing properly. They can see their own plaque. They can see where they've missed brushing. And then I think when it comes to that initial phase of non-surgical treatment that most dentists and hygienists and a lot of your young listeners are probably going to get involved with, then you need to use the right instruments. I use a minimum of 3 tips on my ultrasonic. You need a straight one. It should be very fine so it gets into these deep, narrow pockets. You need at least 1 curved left and 1 curved right to do the mesial or the distal surfaces of posterior teeth. I check all my cleanings afterwards with Gracie curettes. They've got to be sharp. You've got to learn how to use the right site-specific instruments. So there's a lot to this perio treatment that I think hygienists are pretty good at, but a lot of dentists, they skip that part because it's boring or it's gum gardening and they don't want to do it. But with time and patience, it can be done really effectively. And another little secret, a lot of perio surgery, it's really just a bunch of scaling and root planing, except you've raised a flap so you can see what you're doing. Then you can really visualize the root surface, and then you see all the horrors that lie underneath, all the calculus you missed, all of those tricky grooves and furcations and all the places where bacteria like to hide. And of course, where we can, we use materials to regenerate the bone that's missing. We take the opportunity to do that during surgery. There are times where we need to recontour the bone to create a better environment for the patient to keep it clean. But I think even that is changing. We're into more minimally invasive techniques these days. I think the days of huge flaps and massive amounts of bone recontouring are over. I think we can accomplish a lot more with a slightly more minimally invasive technique these days.
And to the young kids also, that's, sometimes you're seeing things and it's confusing. Well, always look behind the curtain. So, I mean, when I got out of school in 87, I'd go to these cosmetic dentistry courses and I would cringe. I mean, some person would come in with all these crowded teeth and they'd prep every one of them down for a crown, and a lot of them looked like rice kernels when they were done and had to have elective endo. And then you notice that when his 18-year-old daughter wanted straight white teeth, he made her go to the orthodontist for 2 years and get bleaching. So whenever you're seeing the profession treating their kids different than the public for money, therein lies the red flag. I mean, it's always been said that world peace will break out when everybody makes decisions based on what's best for their own baby than what's best for getting back at that guy that you don't like. You know what I mean? It's like, forget the guy you don't like. What's the best decision for your baby? So, when it comes to a dentist, and I have this in my practice, a hygienist that's been, fighting a 10 millimeter pocket for 15 years. It's like she's doing everything to hang on to this tooth. Then when it's not a hygienist, and they're like, well, this has been going on a long time. I think we need to step up the treatment and do something more aggressive, pull the tooth and do an implant. Okay, so the people that are pro titanium, they always say, well, what are you doing? It's supervised neglect. You've seen this lady every 3 months for 10 years, and she's still got all this stuff going on. And so it makes the hygienist and dentist feel bad because they think, well, it is kind of supervised neglect. I mean, she comes in every 3 months. We've never cured her from perio. And so what would your answer to that be?
Well, I often say to patients, you don't really cure perio. You can manage it very well. You can stabilize it. You can keep it under control. But it's like high blood pressure. It's like diabetes. It's like a lot of these chronic, non-communicable diseases. They have to be maintained. And I think that in a case like the one you just described, then you absolutely have to put that responsibility back onto the patient. They ultimately have to be cleaning, stopping smoking, turning up for their maintenance visits, and these are the things that often are hard to commit to. Behavior change is probably one of the hardest aspects of providing good periodontal care. And again, back to the comparison with endo. All of that responsibility is on the endodontist or the dentist to get the technical quality right as far as they can. But I think with perio, an awful lot of it comes down to the patient, and that's where these soft skills come in. You've got to be able to listen and communicate and motivate and educate. So I think, as long as the patient's aware of these issues and it's their choice to maintain their own teeth and not be bullied into having them taken out, then I think that's acceptable.
It's there's so many easy rules of thumbs to make better decisions, and one of them is is this decision best for your baby or best for revenge? Is when you hear people talking about themselves, like, would you say that to your own child? Like, you got a baby boy, right? 1 year.
He's one, yeah. Just turned one last month.
Yeah, and it's like, okay, is that the advice you'd give your 1-year-old son 20 years from now when he was in college? I mean, and when people are talking crap about dentistry or themselves or their hygienists or whatever, it's like, would you talk that way if that was your child? You know, if your hygienist was your daughter, would you have just said that in those words? So, you know, there's so many things to keep it real. And I know we went over. And you're such a saint. I mean, gosh, it's only 3:30 in the afternoon on Monday here, and it's 2:00 in the morning in Dubai, and he's there. He is all bright and shiny. Another big one is Perio Protect. There's a lot of people who believe if I take these impressions and make these trays and soak these teeth in Perio Protect, and then other people make trays but use a chlorhexidine gel, or do any of these mouthwashes, gels, products, is any of that having an impact on periodontal disease?
Well, my question there is, how do those products get into any residual pockets? They probably do a great job on the surface. They probably do a great job where they're actually in contact with the tissue. But those are areas that should also be accessible for good brushing and flossing. All the damage is being done underneath the gum. You know, if you've got those pockets 6, 7, 8, 9 millimeters or more, I just wonder whether any topical agent is going to penetrate inside that pocket deep enough to do what it's supposed to.
So you would say no then?
Yeah, I guess so.
that was a no. So you have someone on 3-month recall. Some people wonder, well, if I make trays, Perio Protect, if I start using antibiotics. I know dentists who just, when their 3-month recall comes on, they throw them a script of tetracycline, because they learned 100 years ago that the cyclines show up in the gingival curvicular fluid about 7 times more than penicillin. Some do the Perio chips. Some try to get all their patients to go from brushing and flossing to water picking and ultrasonic. Do you see any of those? Do you think it's more, look, it's genetics, you got diabetes, you're smoking, and as I'm explaining this to you, you just took a shot of Jameson. Is that more of the deal, or is these over-the-counter products, toothbrush, mouthwashes, is all that a big deal?
Well, I think everything you can do to offset those bad habits, it's got to be a good thing. So, you know, everybody's different, everybody's complex and irrational and responds to different incentives. So I think if you can find a way to help those patients maintain their oral health, then that's a good thing. Now, I suppose as professionals, we've got our own biases and our own experiences about what we think is better in certain hands. I'm a little bit concerned that some of those things are seen as revenue generators for clinics, and you know, there's almost like a need to do something, to offer something, you know, to have to do some treatment. But I think, you know, if you're setting your fees appropriately, if you're charging for your time properly, then I think education is important. The key for me in home care is interdental brushing. That was really hammered home to me by a group of great hygienists I work with in Manchester in the UK. My sense from your colleagues in the US is that floss is still the way that you clean between your teeth. Traditional dental floss. In Europe, I think we're moving more to interdental brushes, and I like those. I think patients find them easier. They're thicker, so they're penetrating deeper into the subgingival environment, and I think there is some reasonable evidence to show that they are doing a better job. Flossing is hard. A lot of people think they're flossing, and they may well be flossing, but unless they're doing it right, they're not really necessarily removing a lot of bacteria. You know, it's quite hard to expect a thin piece of floss to physically disrupt and remove everything from under the gums, whereas a correctly sized interdental brush is going to sweep under there and remove a lot more, I think.
So, my gosh, I can't believe how fast this went. We went over an hour. Is there anything you wish we had talked about that we didn't talk about?
Well, Howard, I can't let you go without saying a huge thank you to you because, I only set up this clinic a couple of years ago, and every day I listen to you for an hour with your guests and talking about everything, marketing, social media, some of these clinical things that we talked about today, lease negotiation, you name it, practice management software. You've covered everything, and as you said, you don't necessarily want to talk to people that are playing to the gallery. You want to delve into these controversies. So I haven't always agreed with you, I'll be honest, but I've
Oh
learned
my
so much.
God, I can't believe it. Someone didn't agree with me. I mean, yeah, I mean, that's great. I mean, gentlemen can disagree. I don't want anybody to agree with me. I like to take their mind out for a ride, go out and
Yeah.
start thinking this stuff up. And I know all the kids think their grandpa is crazy. I know my grandpa was crazy. But that doesn't mean that they can't say something that make you think.
Yeah. So all I wanted to say was just a huge thank you for doing these podcasts. And I hope whatever I've shared today has been in some way interesting or useful.
It is. It was amazing. And the only reason this show is a success, it has about 1% me and 99% guys like you, periodontists in Dubai, 2 o'clock in the morning, showered with a tie on, ready to come talk to their sovereign professional colleagues. I love dentistry for that. I mean, you can go, I've heard so many love stories about dentists. Hell, there's a thread on Dental Town. Some dentist's dad is dying, and his dying request was to meet this movie star, and he just shared it on Dental Town. And another dentist found the guy, set it up. I mean, it's like
That's awesome.
it's just a really tight tribe, and
Yeah. Right.
the 11th commandment is don't eat your young. We got so much crazy patients and staff and insurance and whatever. The last person you're going to attack is another dentist on the front lines of cario, perio, and occlusal. And you are on that front line, thinking outside the box, crushing it in Dubai. And on your last email, thank you so much for coming on the show. And I hope you get enough sleep before you go into work.
Well, thanks a lot, Howard. It's so nice talking to you, and thanks again for your time.
All right. Have a great day, buddy.
Same to you, Howard. All the best.